All right, good morning, everyone. I'm Scott Schiffman, Assistant Professor and Fellowship Director of Musculoskeletal Radiology from University of Rochester, and I'm giving a case review live presentation on the topic of meniscal tears. As an icebreaker, just to give you an idea of where Rochester is located, Rochester is in upstate New York between Buffalo and Syracuse. It's about a 3-hour drive to Toronto, and it's about a 1 to 2 hour drive to Niagara Falls. Our MSK section is composed of 6 faculty members, and I've kind of placed this black box around myself so that you have an idea of who's speaking to you today. So the objectives of this presentation is to first off review the normal anatomy of the menisci. Second off is to touch on the basic tear patterns that involve the meniscus as well as their sequelae or complications. And then to review the complex tear patterns involving a meniscus. And then finally to touch on some special cases. With regards to the meniscal anatomy, the meniscus is a C-shaped, when viewed in the axial plane, the meniscus has a C-shaped contour, and then any cross-section through the meniscus will have this triangular appearance, more or less looking like this three-dimensional graphic right here, almost like a wedge shape or a banked turn. And the meniscus is acting as the main shock absorber of the knee, helping to cushion the articular cartilage and the underlying bone. One important thing to realize about the meniscus is, and I'll draw it on this image using a pen, is that the meniscus is connected by these collagen fibers which are running along the circumference of the meniscus. And these collagen fibers is what's producing what's referred to as hoop stress, which helps keep the meniscus well connected without springing apart. Another important thing to realize is that the meniscus is anchored down to the region of the tibial spines, both anteriorly and posteriorly, by these structures called the meniscal roots. So both the anterior horn and the posterior horn have these anterior and posterior root attachments, which help anchor the meniscus down to the tibia. Additionally, on the sides, there are these meniscotibial and meniscofemoral ligaments, which also help anchor the meniscus into place. Now, when describing meniscal tears, an important thing to realize about the meniscus is that the inner portion of the meniscus is referred to as the white zone, meaning that it's avascular and has very limited blood supply. The middle aspect of the meniscus is referred to as a pink zone, or sometimes called a red-white zone, which has some limited amounts of blood supply. And the peripheral 3 to 4 millimeters of the meniscus is referred to as the red zone. And the red zone is the area of the meniscus that has adequate blood supply for healing. Such that if you were to have a meniscal tear involving the peripheral most aspect of the meniscus, either the meniscal tear might be able to heal spontaneously on its own, or with the right intervention, such as suturing the meniscus back together, this might stimulate healing of this meniscal tear. Whereas if a tear is closer to the central portion of the meniscus, basically it's avascular and has limited capacity for healing. Another thing to keep in mind is that while the lateral meniscus is a perfect C shape, the medial meniscus tends to be a little bit more posterior heavy, where the posterior horn of the medial meniscus is a little bit larger than the anterior horn of the medial meniscus. Now, when looking for meniscal tears, the things that you're going to want to look for on imaging is a combination of signal and morphology. What I mean by signal is that we're looking for fluid signal intensity that's linearly oriented and is unequivocally contacting or breaching a surface of the meniscus. The two surfaces of the meniscus is up here, this is the superior surface, and down here, this is the inferior surface of the meniscus. So here we see an example of a linear, horizontally oriented high T2 signal line, which is breaching the superior surface of the meniscus, and this would be a horizontal tear of the posterior horn of the medial meniscus surfacing superiorly. So this is based on signal and the fact that it's unequivocally breaching the surface. Now, this example on the right is an example where we also have some mildly elevated T2 signal, also linearly oriented, but it doesn't unequivocally approach the surface. Dr. Resnick has a good point with regards to meniscal tears, which is that you should sit back comfortably in your seat. You shouldn't feel the need to go CSI and magnify the image like 1,000-fold to try to find one pixel that might violate the surface. You should be able to do this without zooming in, comfortably resting in your seat, you should be able to unequivocally say that it's contacting a surface. And if you're unable to do that, then most likely you're not dealing with a meniscal tear. This patient had a meniscal tear in the opposite meniscus and lateral meniscus, so they did go in arthroscopically, and this medial meniscus wound up having no tear at the time of arthroscopy. Now, when referencing morphology, mainly referencing the shape of the meniscus. The meniscus should have this nice triangular shape with a nice pointy tip. And if any of that shape is lost in terms of morphology, that would point you towards a tear. So in this case, we could see that rather than having a triangle, it looks like we have a trapezoid. And then we have a tiny little triangular tip down here. So this gap in between and this change in morphology would let us know that we have a tear at this location, in this case, a radial tear. And we'll review this in much more detail about how to recognize these types of tear patterns. But I just wanted to illustrate the basics of understanding meniscal tears. All right, so before we move on to the actual case presentation, I wanted to first show the basic tear patterns of the meniscus using this Microsoft Paint. So the first tear pattern that we're going to discuss is referred to as a horizontal tear. And what a horizontal tear is basically almost looking like if you're cutting the meniscus straight down the middle like a sandwich in a horizontal direction. So what we have here is what the meniscus looks like in an axial plane. And what we have here is basically any cross-section along the spoke wheel of the circle where we're winding up with a triangular image of what the meniscus looks like on cross-section. The horizontal tear basically extends from the inner surface of the meniscus horizontally across the substance of the meniscus as such, basically splitting the meniscus into an upper and lower half, or simulating like if you were cutting like a hot dog or a sandwich in half. In the axial plane, you won't be able to see this tear because this tear is running in the same directionality as the axial plane. Now, the main complication of the horizontal tear is that fluid from the joint will be able to seep through this crevice and pop out the other side, forming what's referred to as a parameniscal cyst. So the complication of the horizontal tear is equal to a parameniscal cyst. Now, something to know about the horizontal tear is that these tears are typically degenerative in etiology. They don't have an excellent surgical solution, but the good news about the horizontal tears is that you still maintain your volume of meniscal material. So to an extent, you still have a shock absorber, but the main problem is that some of these parameniscal cysts can cause pain by mass effect. And also the tear itself does create some micro instability within the meniscus, which can lead to osteoarthritis of the knee. But there's no good surgical technique because the tear is violating the red zone, the red-white zone, as well as the white zone. So that's the horizontal tear. The next tear that I would like to talk about is the vertical tear. And the vertical tear is more appropriately named a vertical longitudinal tear. And what a vertical tear is basically a tear that's going to run from top to bottom. It's vertically oriented. And one of the key features of the vertical tear is that it's always the same distance from the outer margin of the meniscus. And it follows the contour of the meniscus, meaning that if you look at it in the axial plane, a vertical tear will kind of parallel the collagen fibers of the meniscus. Oh, and even though I can't draw it completely appropriately, it always stays the same distance from the outer margin of the medial meniscus. And one thing you'll notice is that the tear never contacts the inner surface of the meniscus. It always stays somewhat peripheral. So this is the hallmark findings of a vertical tear, meaning that it's longitudinally oriented, it's running from top to bottom, it's vertically oriented, and it never contacts the inner surface of the meniscus. So the complication of a vertical tear is that if this vertical tear is kind of allowed to come close to completing itself, it doesn't necessarily have to complete itself, then with the right amount of force in this direction, you could wind up with displacement of this fragment. Either this fragment will basically invert and flip inwards into the joint, or it'll get distracted and pulled into the joint. But no matter what, it's going to wind up looking something like this diagram that I'm about to draw. So when this segment gets pulled inward, it takes on the appearance of what's described as a handle. where the remainder of the meniscus is described as a bucket. You could kind of imagine putting your hand underneath this handle and basically carrying the meniscus, which is the bucket. So be aware that the complication of a vertical tear, if it goes unchecked and the right amount of force occurs, is a bucket handle tear. So I'll write that in right here. Now, the vertical tear is interesting because this at times does have good solutions. You'll notice that vertical tears tend to be more peripherally oriented. So they tend to be closer to the red zone or the red-white zone. So more propensity for healing. And also more propensity if the surgeon wants to suture it together and see if it'll heal. So that's one of the advantages of a vertical tear. And then it seems like surgically, even if it doesn't heal, it seems like there's an easy solution, which is that you just kind of remove the meniscal material that's not healing. You kind of remove what would be the handle. And then basically all you have left is this thin peripheral rim of meniscus material. So from a surgical perspective, you're looking for either the tear to heal or you're looking to create a nice new smooth margin, leaving behind a thin shell of meniscus material. Now, finally, the last basic tear pattern is the radial tear. And the way to think about a radial tear is imagine placing the center of the circle right at the center of the meniscus, and then imagine cutting the meniscus along the radius of this circle. So it somewhat takes on the shape of a spoke wheel appearance, meaning that you could have a radial tear shaped like this. I could create a radial tear shaped like this. I could create a partial radial tear here. I'm going to create a partial radial tear here. And now I'm going to create a full radial tear here. And sometimes these radial tears can have some width to them. So here I'll create a radial tear that has some girth to it. Now, radial tears, because of how they're looking in the axial plane, can take on varying appearances in your coronal and sagittal planes based on how you're cutting the tears. So you need to be familiar with a few signs to recognize the radial tear. Probably the easiest one to conceptualize is imagine having a plane that's parallel to a full thickness radial tear, meaning that I'm going to create a sagittal plane. Here's image 1, here's image 2, and then here's image 3. You'll see that this full thickness radial tear, when it's parallel to the plane of imaging, you'll wind up seeing the meniscus, then the meniscus will disappear for a slice, and then when you go to the next slice, the meniscus will reappear. This phenomenon where the meniscus disappears for a slice is referred to as a ghost meniscus sign, and this is a pathognomonic for a radial tear. I also think about this as almost like being in the eye of a hurricane, meaning that when the eye of the hurricane is here, you don't see it, and then you could see it when the eye of the hurricane moves out. Similarly, if you had a plane that was parallel to a partial thickness radial tear, for example, this one, you would expect to see basically a truncated portion of the meniscus, meaning that you would see what looks like a trapezoid, and this tip of the meniscus will be absent. So when you see a truncated portion of the meniscus, that's another sign that tells you that you're probably looking at a radial tear. A third sign to keep in mind now, I'm going to delete some of these planes. A third sign to keep in mind is if you have an obliquely oriented radial tear and your imaging plane is capturing it on multiple slices, one thing that you're going to encounter is that on one slice, you're going to see it almost looking like a vertical tear. And then on the very next slice, it'll also look like a vertical tear, but it'll be moving. Meaning that between slice number 1 and slice number 2, it's either going to move inward or outward. This is referred to as a marching cleft sign, and the marching cleft sign is also pathognomonic for basically a radial tear. It just means that you're imaging an oblique tear, like a radial oblique tear, on 2 successive slices, and it's moving in direction. I'll point out that the vertical tear always stays the same distance from the outer margin of the meniscus. This helps separate it from the radial tear. And the radial tear also always touches the inner margin of the meniscus. So to summarize some of these signs, we have our ghost meniscus sign, we have a truncation of the meniscus, and we have our marching cleft sign. These are some of the signs that you want to look for with a radial tear. Now the main complication of the radial tear is, as we've discussed, there's these collagen fibers that are running along the course of the meniscus, which help to maintain the hoop stress of the meniscus and keep everything more or less anchored into place. When you create a large radial tear or any radial tear that goes through these collagen fibers, especially when it's a full thickness radial tear, it results in basically disruption of the hoop stress, and you no longer have things anchored into place. So what winds up happening is you wind up with meniscal extrusion. So the main complication of a radial tear is going to be meniscal extrusion, meaning that the meniscus is going to jut away from its normal position and extend outward. So now that I've kind of reviewed these basic tear patterns, I just wanted to diagrammatically show these. I want to show some cases that illustrate these patterns. And if you guys would like to participate in the chat as I'm showing the cases, feel free to enter into the chat what diagnosis you think it is, and then we'll move from there. So I will load up the first case. All right, so before we get into the pathology of the first case, I'm going to kind of pan around and kind of show you the anatomy of the meniscus and how I look at them. So my favorite plane of looking at the meniscus is the sagittal plane, and I've heard other presenters like Stoller particularly prefer the coronal plane. But I think eventually, no matter how you look at a meniscus, you're going to want to take all three planes and combine them in your mind, and you're going to want to try to map out what it looks like in 3 dimensions. And when you have this nice 3-dimensional picture, that's going to help you when you're trying to decide what tear you're looking at. So when I'm on the medial aspect of the knee, the key thing is that the tibia takes on the shape of a golf tee, where the medial femoral condyle looks like a golf ball on the golf tee. And when I go to the lateral side of the knee, the tibia kind of takes on the shape of like a upside down boot. So I'll show you that. It kind of has this type of appearance where it looks like an upside down boot or a hockey stick. And then as I go a little bit further, I could see the fibula. So that helps me find that I'm on the lateral side of the knee, and this is the medial side of the knee in the sagittal plane. Now, the anterior and posterior horns of the lateral meniscus are more or less equal. The lateral meniscus is really shaped like a C, and it kind of takes on this bow tie-like appearance. I'm going to go to the posterior root attachment of the lateral meniscus, which is right back here. I'm going to kind of pan backwards to see the posterior horn of the lateral meniscus. I'm going to continue into this rectangularly shaped body of the lateral meniscus, moving forward to the anterior horn of the lateral meniscus, and then to the anterior root attachment of the lateral meniscus, which is right here. Now, as I move on to the medial meniscus side, this will be the anterior root attachment of the medial meniscus. I'm heading into the anterior horn of the medial meniscus. This is the body of the medial meniscus. Here's the posterior horn of the medial meniscus. And then back here is the posterior root attachment of the medial meniscus, right deep to the PCL. So I will pause the image on this slice right here. So I'll ask the audience for any diagnoses in the chat. But this is demonstrating one of the 3 types of meniscal tears that we just went over. And if I don't see any answers in the next like 30 seconds, I'll just kind of narrate the case.
Perfect. In that time, I just want to make the note that the names on the case are not actually the names. These cases have been anonymized.
All right, great. So we're getting some responses, and all the responses are accurate. We're dealing with a horizontal tear. The horizontal tear is surfacing inferiorly mainly, and the horizontal tear is associated with this parameniscal cyst, which is posterior to the posterior horn of the medial meniscus. On the coronal plane, again, just as a review of anatomy, this is the posterior root attachment of the medial meniscus. Here's what our posterior horn looks like in a coronal plane. We could see that nice horizontal tear cutting the meniscus in half like a sandwich. As I move posterior to that tear, I'm encountering this large parameniscal cyst, which looks even larger than you would guess on the sagittal images. Yeah, so this is a good diagnosis for the horizontal tear with the parameniscal cyst. Here's the body of the medial meniscus in the coronal plane, and here's our anterior horn of the medial meniscus. Similarly, the anterior root attachment, lateral meniscus, anterior horn, body, posterior horn, posterior root attachment, and meniscofemoral ligament right here. So that's just a brief review of the anatomy. Loading up another case that's very similar to this one. So we have another patient, very similar pathology. Again, we see a horizontal tear involving the posterior horn of the medial meniscus. This one is surfacing superiorly. And when I see a horizontal tear involving the meniscus, I'll kind of pan around. And I encounter this parameniscal cyst, which is located behind the posterior horn of the medial meniscus right here. And then another interesting observation is as I get closer to the root of the medial meniscus, I'm encountering what I would refer to as an intrameniscal cyst. So you could want up with these tears basically having fluid communicating to a parameniscal cyst, or the fluid can also communicate and basically deposit within the meniscus, forming this intrameniscal cyst located right here. All right, so moving on to another case example. So we have this patient. I'm in the sagittal plane. Here's the posterior root attachment. As I'm coming back from the posterior root attachment, I'm encountering this abnormality right here. I'll ask the chat again to, within the next 30 seconds, give some attempts at diagnosis for this abnormality. I'm going to pan around. We could see that the abnormality is somewhat vertically oriented. It kind of remains the same distance from the outer margin of the meniscus. When I look at it in the coronal plane, I could see that not only was the posterior horn involved, but as I'm marching forward, a very thin sliver of meniscal material has been displaced from its parent with this vertically oriented signal abnormality. And even as I'm heading more anterior towards the anterior horn, I'm seeing that same signal abnormality. When I look at this in the axial plane, every now and then you could catch this very nicely. And we could see that the signal abnormality is basically taking on the contour of the C shape of the medial meniscus. All right, great. So I do see in the chat that people are commenting that we're looking at a vertical tear involving the posterior horn and body. In this case, it even extended to involve the anterior horn, but you would really need the axial plane to help you build that picture in your mind. And then the complication that could occur with this vertical tear is the bucket handle tear. This patient actually did not have a bucket handle tear, and this is far located in the periphery. So this tear might have a good prognosis in terms of healing if it's managed surgically. I'm going to pull up another case. All right, so here we have a patient that has had an anterior cruciate ligament rupture. And then as we're going off to the posterior horn of the lateral meniscus, we can see that the posterior horn of the lateral meniscus is just completely destroyed. This is what I would refer to as a complex tear because basically tears are headed in all directions. But when I move over to the posterior horn of the medial meniscus, we could see on several slices extending from the posterior root, posterior horn, several slices we're seeing this signal abnormality that's linearly oriented, the same distance from the outer margin of the meniscus. We can see that the capsule, the posterior capsule is still adherent to this fragment of the meniscus. And we could see that this tear basically propagates all the way from the posterior horn to at least involve the posterior horn body junction. And it always stays the same distance from the outer edge, and it never gets approaching the inner edge of the meniscus. Here's the axial plane on the same patient, and we could see that signal abnormality basically paralleling the course of the C, and it basically extends from the posterior root attachment almost to that body / posterior horn junction of the meniscus. So here's another case of a vertical tear involving the posterior horn of the medial meniscus. Now, the reason that I wanted to show this case in particular is because this type of a tear has an association with ACL injuries. And the reason behind this is that when you have an ACL tear, you create a situation where you have some anterior instability of the tibia. So when the tibia translates anteriorly, it creates a situation where the femoral condyles is going to put direct stress on the posterior horn of the medial meniscus. And this direct stress oftentimes results in this vertical tear. So when you're looking at patients who have had a prior ACL tear, prior ACL repair, or if you're looking at a case with an ACL rupture, you want to look at the posterior horn of both the medial and lateral meniscus, and you want to look for the possibility of either a vertical tear or you want to look for a bucket handle tear, because as we said, the bucket handle tear is a complication of the vertical tear. So just be aware that these are associated with the ACL injury. All right, so moving on to our next mystery case. I will show the case and then I will ask the audience to provide some diagnoses in the chat, and I'll give about like 30 seconds to a minute for people to enter diagnoses. I will show this first in the coronal plane. Right now I'm at the posterior horn of the medial meniscus. As I start moving forward, okay. As I start moving forward, I could see that the meniscus is taking on somewhat of a truncated shape, and there's this displaced fragment of meniscal material that's going to start entering the intercondylar notch. And then as I keep moving forward, I see that this is a very truncated, the medial meniscus body's lost a lot of volume, probably because a lot of its volume has gone in this direction. And then as I go further back and I start approaching the anterior horn, I can see that this fragment starts merging again back with the anterior horn. So basically from anterior to posterior, I'm seeing it split apart, enter the intercondylar notch, and then basically rejoin posteriorly. Then in the sagittal plane, as people are pointing out in the chat, we do have this nice imaging feature of the double PCL sign. So when this meniscal material displaces into the intercondylar notch, basically it creates an imposter in the sagittal plane, where this is our normal PCL back here, and this is the imposter, which is basically that the handle or displaced portion of meniscal material, which is the bucket handle tear. As I pan around on the sagittal plane, you can see that there's been significant volume loss of the posterior horn and even of the anterior horn of the meniscus. And the reason that there's been volume loss is because as we pan around, we can see that there's this displaced fragment that's projecting centrally within the intercondylar notch. So very good by the chat. We do have that bucket handle tear of the medial meniscus with the flipped fragment producing the double PCL sign, or the bucket handle tear. Every so often you get a nice look at these in the axial plane. I have seen better examples, but I wanted to specifically include this example. And after a while, you get used to looking at these things and it makes sense after a while. But right here in the medial meniscus, if I'm kind of panning between these two slices, I'm kind of hallucinating that I see this, the handle of the bucket handle tear doing one of these things right here, where we have the native strip of the meniscus material has been markedly reduced. I need to pan around just a little bit to figure out what I'm looking at. But the native meniscal material might be doing something like this, but it's markedly reduced in terms of its thickness. And the reason is because half of its volume is basically flipped inwards, forming this handle. So every so often you catch this very nicely in the axial plane is what I wanted to show. All right, so yes, that was the bucket handle tear. I'm going to move on to one additional case example of this type of pathology, but this time involving the lateral meniscus. And this one I think is a little bit more confusing. And I haven't shown you this one on a diagram in paint yet. So here we are, we're looking at a case. The patient has had an ACL tear. Here's the medial meniscus. Um, and then as I'm going to the lateral meniscus, I'm encountering already, like by the posterior root attachment, I'm encountering significant volume loss of meniscal material. Like I'm not seeing exactly the posterior root of the meniscus. And I'm also seeing this linear signal abnormality involving the posterior horn of the medial meniscus. And then when I look anteriorly, I'm seeing basically a fast forward sign. I'm seeing basically two triangles, and both of these triangles can't be the anterior horn of the lateral meniscus. So does anyone know what this is referred to? I mean, this is also a variant of a bucket handle tear involving the lateral meniscus, but do any of you know the proper term for this phenomenon? All right, excellent. So someone in the chat has entered in the correct diagnosis, which is a flipped meniscus. What's going on here? Watch as I pan around. I could figure out which one is the native anterior horn. It's going to be the one that attaches to the anterior root attachment of the lateral meniscus, which is right here. So this is our lateral meniscus, and this is our imposter. What's happened here is the posterior root of the lateral meniscus is basically torn, and it is flipped forward and inverted in such a way like so. Where it's now laying basically right behind the anterior horn of the lateral meniscus and basically flipped upside down. So this is referred to as a flipped meniscus. And nicely in the axial plane in this case, when I kind of get to the proper image, we could make out the native anterior horn right here, and then we can make out this imposter right behind it. This is the flipped fragment, which is basically flipped forward from the posterior horn and is laying right now behind the anterior horn of the lateral meniscus. So this is another type of a bucket handle tear, largely the result of a vertical tear. And obviously, when you have meniscal tears that produce fragments like this, they're referred to as unstable. And these need to be resected, because anytime you have basically a fragment that's encroaching on the intercondylar notch, you're going to have clicking, locking sensation, and it's basically something that needs to be managed by removing this portion of the displaced meniscal material. So this is referred to as an unstable meniscus tear. All right, great. So we're going to move on to another example, again covering some of our basic tear patterns. Um, This one might be a little bit more confusing if you've never seen something like this before. And that's the reason I'm including this axial projection when I'm looking at these coronal and sagittal projections. Because if you haven't seen a lot of these types of tears before, you might get confused just looking straight at the coronal and sagittal projections. But I would like to point out that, again, we're looking at the medial meniscus. Here's the anterior root attachment. I'm entering the anterior horn, then I'm entering the body of the medial meniscus. And then as I go further posterior, the meniscus starts to lose volume, and then eventually it disappears completely. And then it disappears completely for a few slices. And then when I go to the proper slice, then it reemerges. And I'm seeing the meniscus, and then I could see the posterior root attachment. But there's several coronal slices where the meniscus basically disappears. On the sagittal projection, I'm seeing the meniscus having two truncated borders, one on the posterior aspect of the medial meniscus body, and one anteriorly on the posterior horn of the medial meniscus. And there's this unusual gap that's in between these areas of truncation. Yes, so in the chat, people have described the radial tear and the ghost meniscus. Oh, sorry, sorry, this was the lateral meniscus. Sorry about that. But great, in the chat, people are describing the ghost meniscus referring to that eye of the hurricane, meaning that you could see where my cross-sectional slice is on this axial image. As I migrate into the tear, it basically disappears. That's the ghost meniscus. And then here as we refer to, anytime you see truncation along the inner margin of the meniscus, you should be thinking that you're dealing with a radial tear. So this nicely, I think on the axial, this nicely demonstrates that radial tear with the large gap that has been created by a displaced radial tear. And then you'll remember that the main complication of a radial tear is extrusion, meaning that we've lost the hoop stress, the meniscus is no longer really connected that well. So eventually these portions of the meniscus will be able to kind of protrude from the joint because there isn't much other than the root attachments that's anchoring this into place anymore. So very commonly in people that have radial tears, they wind up losing a lot of cartilage on the side of the radial tear. They've basically lost the shock absorber. You can see there's no more shock absorber at this location, and then you could see that the articular cartilage of the lateral compartment is basically almost completely lost. And this is very common in people that have these radial tears. Also, people with meniscal extrusion, it's very common to lose cartilage. So I would say out of these three tear patterns, out of the three basic tear patterns, the one that you would want the least is the radial tear. I mean, first off, it's violating the white zone, the red-white zone, and the red zone. And then second off, you're losing your hoop stress, and you're eventually leading to more progressive osteoarthritis with cartilage on cartilage and eventually bone on bone. So that's something to keep in mind. Now, a special type of radial tear, which I think you need to be aware of because these are quite common. You're going to see these, and I'll just kind of I'll talk my way through this case since I'm kind of alluding to it. But this is the idea of a posterior root tear. So what a posterior root tear is basically a radial tear that's occurring at the posterior root attachment of the meniscus. In this case, I'm going to be showing what it looks like involving the medial meniscus. So right here, we have our medial meniscus body. Here's the posterior horn of the medial meniscus. And then as I start approaching the posterior root attachment, I'm going to see that this meniscus disappears for a slice, disappears for a second slice, and then I kind of make out a small nubbin at the attachment of the posterior root. But basically, there were two slices where this meniscus disappeared. Also, as we've discussed on the previous case, that's referred to as the meniscal ghost sign. When I look at this in the coronal plane, I see this thin sliver of posterior root attachment of the medial meniscus, and then I'm seeing this truncated gap where the radial tear is located, and then I'm seeing the posterior horn of the medial meniscus. So this is also the radial tear involving the posterior root attachment of the medial meniscus. When we look at it on the axial plane looks as how you would expect it. Here's our radial tear, which is occurring between the posterior root attachment and the posterior horn of the medial meniscus. So the main complication of this posterior root tear is that you're going to wind up with extrusion of the meniscus body. So you've lost your anchoring point posteriorly, you've lost some of your hoop stress, and then as you go to your medial meniscus body, it shouldn't shock you to find that the meniscus is extruded. And when I say extruded, I mean that the meniscus should line up like a triangle where the points of the triangle are basically articulating with the edges of the femur and the tibia, similar to how the lateral meniscus is looking on this image. But you could tell that the medial meniscus has migrated. I'll kind of draw an arrow. The medial meniscus has migrated medially by a few millimeters, and by migrating medially or extruding medially, it's left the cartilage with very little shock absorber, and you can see that this patient is basically losing cartilage in the medial compartment. So be aware of this phenomenon of the posterior root tear. It's a commonly missed tear by residents. But I think after a while, once you start reading a lot of knee MRI cases, you'll see that this tear is quite common and really should not be missed. And the sequelae of such a tear leads to progressive osteoarthritis, sometimes even subchondral insufficiency fractures as a result of basically no more cushioning or no more shock absorber, particularly in osteoporotic patients. So that posterior root tear is another variant of the radial tear, basically. I will now kind of like move the attention onto some more complicated tear patterns. So I'm going to minimize our little diagrams for the basic tear patterns, and we'll move into some more complicated tear patterns. Now, when I say complex tear patterns, the thing I'm referring to is basically combinations of tears. So imagine that we have a radial tear meeting a vertical tear. Like imagine the tear begins as a radial tear and then decides to change its orientation and become a vertical longitudinal tear. Then you kind of are creating this inner flap of meniscal material, which will eventually displace like a trap door. And eventually you're going to have an imaging appearance. And forgive me, I can't draw this that great, but you'll have an imaging appearance that more or less looks like this. When you see an imaging appearance where you have a displaced flap of meniscus material projecting inwards, telling you that you're originally dealing with a radial tear, this phenomenon is referred to as a parrot beak tear, because the shape of this flap takes on the appearance of like basically the beak of a parrot. Another type of complex tear pattern is imagine you had a horizontal tear involving the undersurface of a meniscus, and then that changes orientation and becomes a radial tear. And then you've created this somewhat triangular fragment of meniscal material, which has been kind of sheared off of the inferior edge of the meniscus. This fragment might displace almost like a trap door, and it might fall into either the inferior, or if it's on this side, it might fall into the superior gutters of the meniscus. This phenomenon is referred to as a flap tear. Both of these cases, this could be described as a flap tear because they're both flaps, but I think this one in particular along the inner edge, where it creates kind of this like shark fin-like appearance, is more conventionally termed the parrot beak tear, whereas this tear that's kind of sheared off of the inferior or superior borders of the meniscus and gets displaced into the gutters is more commonly called a flap tear. So I wanted to show examples of this phenomenon just so that you've seen this on MRI. So let me load up a patient. So I will ask the audience that you take a look at this image and let me know what type of tear pattern you think is going on an image like this. And then, okay. And then we will take a look at this axial image and we'll try to complete the story with giving like a more formal diagnosis. Okay, great. So we're having some responses for flap tear. So the abnormality right here, I believe I would describe this as at least a radial tear, because we're seeing kind of like this vertically oriented line. It's not always saying from the outer edge of the meniscus. It's more centrally located. I believe it's going to contact the inner margin of the meniscus. It is kind of doing like almost like a marching cleft sign. So this is looking somewhat like a radial tear. And then in the axial plane, all right, great. In the axial plane, when I kind of encounter this region, I'm seeing this as having this displaced edge of meniscus material, and then I'm seeing I'm seeing the rest of the meniscus looking more or less like this. So we have this tear pattern that's involving the posterior horn of the medial meniscus, and it's resulting in this displaced flap of meniscal material inwards. Um, the more appropriate name, I do agree with flap tear, and I think that's perfect. But the name that comes up sometimes when you're looking at the literature would be the parrot beak tear, because of kind of this shape of the tear pattern. And this is what happens when the radial tear is combining with a longitudinal tear. It kind of creates this like shark fin or parrot beak like appearance. So this is what a parrot beak tear looks like. I will show another case. All right, so in this case, I'm approaching an area where I am seeing a meniscus tear. There's this kind of strange linear signal that's running vertically. It's only really present for 1 or 2 slices. I do see some signs of maybe some volume loss on the undersurface of the meniscus right here. And then I'm seeing this weird a meniscal fragment that's located right here. And when I look at this on the coronal plane, as I pan around, here I'm encountering a portion of that tear. And then as I move more anteriorly, I'm seeing this additional meniscal material projecting in the inferior gutter. By inferior gutter, I'm talking about this space between the medial tibial plateau and the medial collateral ligament. This, I'll kind of outline it. This is the extra meniscus material right down here. In the axial plane, here's our meniscus, and then when I go 1 slice lower, I could see this displaced flap of material, which is displaced into the gutter between the medial collateral ligament, or in this case, the medial retinaculum and the medial tibia. So this is what's referred to as the flap tear. And the pathognomonic sign in terms of MSK imaging, this is called the meniscal comma sign, because the appearance of this flap tear, especially when it's displaced in the inferior gutter, takes on the appearance of the comma symbol that you would use to separate a sentence. So this is called the meniscal comma sign. If this same type of flap tear was more superiorly oriented, I've seen some people refer to this as the meniscal apostrophe sign. Because then it would just be basically looking like a comma, but it would be higher up looking like an apostrophe. This tear pattern is something to be familiar with. And the reason that it's important to note this tear pattern is because when the surgeons go in, they're going to go in centrally and they're going to find a meniscus tear, but they won't necessarily know that this flap exists. They need to kind of maneuver their scope around the meniscus to get a good look at this flap. So if they know in advance that they need to do that, that will help them find this portion. And then basically they have to cleave this off because you can't leave a flap like this located here. It causes the patient a lot of pain. These flap tears inevitably are associated with reactive marrow edema. In this case, we see the reactive marrow edema involving the medial tibial plateau here. If you had the meniscal apostrophe sign, then you also wind up with marrow edema involving the femoral condyle. All right, great. So hopefully this makes some semblance of sense. The complex tears are more difficult to understand than the basic tear patterns. I wanted to show just a few more case examples, which I feel like would be helpful. So we have another patient with an anterior cruciate ligament tear. And then as I go posteriorly to the posterior horn of the medial meniscus, I could see that the capsule is not adherent to the posterior horn of the medial meniscus. And there's this vertical fluid crevice. Like you may have seen in other cases, basically the capsule basically firmly attaches to the posterior horn of the medial meniscus. But here we see signal abnormality and a vertically oriented signal at the meniscocapsular junction. When you see fluid-like signals separating the capsule from the posterior horn of the medial meniscus, this is referred to as meniscocapsular separation. And this is just something to be aware of. This is also commonly seen in patients who have had anterior cruciate ligament tears. In this case, not only did the patient have this meniscocapsular separation, but on the coronal plane, they also had this signal abnormality in the periphery of the meniscus. All right, so here's our coronal plane, and when we line it up with our axial plane, we could kind of make out that we could see this, here I'll do localizer mode so you can see where this lines up. You could see that this linear signal abnormality basically is extending from the body to the posterior horn of the medial meniscus. This would be a peripheral vertical tear. So this patient had meniscal capsular separation, but also additionally had a vertical tear involving the peripheral aspects of the body and posterior horn of the medial meniscus. Now, the hard part about vertical tears in general is when a vertical tear is located a little bit more centrally, like say like right here, like I've shown in earlier cases, it becomes somewhat of a no-brainer because you can nicely see meniscus on both sides of the tear. But the more peripheral that these vertical tears get, the less meniscal material you're going to wind up with separated from the parent meniscus. And sometimes it could be even this like tiny sliver. So it's important to not breeze by these images and basically think, oh, this looks like the meniscus is normal, and who knows what this is. Um, so when you wind up with these thin slivers of meniscus, that's how you can miss a vertical tear, basically, is when you have these thin slivers. Sometimes it helps to look at like a proton density or T1 sequence to help figure things out, or sometimes it helps to kind of combine that axial plane to see that linear signal abnormality that's kind of paralleling the course of the meniscus. So hopefully that makes sense. Um, I'm going to move on to a rare occurrence that could happen following a posterior root tear. You may or may not have ever encountered this, but you could see that this patient has had an old posterior root tear of the medial meniscus because we don't really nicely see the attachment of the posterior root. And then as we're going towards the posterior horn of the medial meniscus, we encounter kind of this globular signal, globular elevated signal that's really localized to that posterior horn, posterior root region at the region of probably an old posterior root tear. And if you're just relying on your intermediate fat SAT images, you might think that this is just mucoid degeneration involving whatever's left of the posterior root or posterior horn. But then when you look at your T1 images, you can see that the substance that's actually making this up is actually very similar to a bone in density or in signal. And I'll let you know that we do have a plain film on this patient, which I can't show because I was only able to save the MRI. But on the plain film, there was a bony density at this location. Have any of you guys heard of what this pathology is? If so, can you enter it into the chat? And if I don't see an answer in the next 30 seconds, I'll just narrate the situation. All right, great. So I do see some responses where someone's saying avulsion fracture and someone's saying metaplastic ossification. Metaplastic ossification is very interesting. And I do think to a certain extent that's what's going on here. This is what's referred to as a meniscus ossicle. And it's just a very rare phenomenon. People don't necessarily know what causes the meniscal ossicle, but the key is on a plain film not to get confused calling this a loose body. And also not to get confused on the MRI by using your T1 sequences to convince yourself that you're looking at bone. And there was a very nice paper from Thomas Jefferson University where they found the strong occurrence of these with people who have had previous posterior root tears. So most likely there is some element of trauma which leads to the formation of these ossicles. Because we're running somewhat low on time, I'm just going to show one last case. I'm going to show two variations of it. Before I show the case, I want to diagrammatically kind of show what's going on. So the case that I'm about to show is referred to as a discoid meniscus. So I'll write that down here for discoid meniscus. And basically what a discoid meniscus is rather than having the appearance of a C, the discoid meniscus is looking like a disc. So you can imagine that rather than looking like a C, it'll look almost like a CD or a Frisbee, where the meniscus is basically looking like an O. I can't actually delete all of this, so pretend I was able to delete all of these marks. But the meniscus is abnormally enlarged and shaped like a circle rather than a C. And also the appearance on the coronal plane will take on more of a rectangular shape. So let me load up a nice patient example so that you could see what this looks like. We have a pediatric patient here, and we are looking at the lateral meniscus. And you could see that as I'm kind of panning around on the lateral meniscus, when I get to the lateral meniscus body, there's never a slice where the lateral meniscus kind of takes on that triangular shape. And the triangular shape usually only takes up like 20% of the tibial margin. This is taking up almost like a 90% of the tibial margin. It's this humongous rectangle. And then on the sagittal images, you'll notice that when I'm in the body of the lateral meniscus, I could see this for 1 slice, 2 slices, 3 slices, 4 slices, 5 slices, 6 slices. They never separate into the typical bow tie configuration that you're used to seeing. So when you see this abnormality persisting involving the body for more than 2 or 3 slices, that's telling you that you're looking at basically a discoid variant of the meniscus, where it's no longer that nice C shape, but more of like a O shape. Let's see if we could catch it nicely in this. Oh, we can't. So it's very hard for me to show you exactly what's going on in this axial plane. Now, the key thing about the discoid meniscus is that the discoid meniscus is prone to mucoid degeneration and eventually meniscus tearing. So you wind up with a very higher incidence of meniscal tears involving discoid menisci. It seems almost on the surface, it seems like a good thing. Like, oh, great, I have more shock absorber. I should be, I should be like 90 years old and not having osteoarthritis. But in essence, the discoid meniscus is actually not a good thing to have because the collagen fibers are haphazardly oriented and it leads to more degenerative changes and tearing. So to show you an example to kind of like finalize our discussion for the morning, here's a patient. And I mean, the image quality isn't as good as the last one, but you could see that the lateral meniscus is taking up much more than 20% of the tibial plateau. And the lateral meniscus body is extending quite a distance. And then you could see in the sagittal plane that our lateral meniscus body takes up 1 slice, 2 slices, 3 slices, 4 slices, 5 slices, and it never quite separates into that nice bow tie-like configuration. Now I'll ask the chat to see what we've learned from this presentation. This discoid meniscus does have a tear. So what type of tear pattern is involving the discoid meniscus and what complication are we seeing? All right, great. So someone has pointed out the horizontal tear. I do agree with that. We see this horizontally oriented line cutting it down the middle. And what complication of the horizontal tear are we seeing? All right, great. So we do have this parameniscal cyst anteriorly. Great. So that kind of gives some perspective to some of the topics we've talked about earlier. Because I still have a good 5 or 6 minutes, I do have some bonus cases which we can look at. So I'll open up some bonus cases and I'll just kind of pose them to the chat so that you guys could try to make some diagnoses. And then basically once we get to 11 o'clock, then we'll basically we'll stop showing cases and we'll just take questions. So this case, I'm going to show that there's something going on in the medial meniscus body here. And then as I go posteriorly, I'm encountering some weird region right here. And then when I'm looking at this in the sagittal plane, I want you to focus on the slices between here and here. So I would like you to try to give me an idea of what's the tear and what's the complication that's occurring. All right, great. So we do have one. Okay, we're having a few answers in the chat, and all the answers are basically saying that we have a posterior radial root tear, which I agree with. There is a ghost phenomenon, which I agree with. And what's the complication that I'm trying to show on this image? All right, great. Yeah, so someone did say extrusion. Here, if I had to put a measurement on it just so that you could see how I'm thinking, I would say that the meniscus is basically extruded practically 5 or 6 millimeters. And then basically you could see that the meniscal body is basically undergoing mucinous degeneration and we're losing cartilage on the medial compartment. When you have this reactive marrow edema and you have areas of cartilage loss, these are all side effects of that posterior root tear. Okay, and one last case, and then we'll kind of turn to questions. This case has a few findings, so let me try to open up some 3 planes here. All right, so I'm showing an abnormality involving the medial meniscus, and I'm going to pan around a few slices. I'll say that the abnormality is present on almost every slice that I'm panning on. And so I would like you to enter a diagnosis into the chat based on what you think is going on involving the medial meniscus. I'm showing it again on the coronal plane. And I'll again show it on the axial plane. It'll be located back here. All right, great. So I'm seeing an answer for the vertical tear in the red zone. And now I'm going to move over to the lateral meniscus side on this patient. And I would like you to enter a diagnosis into the chat on what you think is occurring involving the lateral meniscus. And I'm panning around on a few slices. I'll see if I could find it on the axial somewhat. All right, great. So we're seeing multiple responses for flipped meniscus. So that's accurate. So basically, we're missing our posterior horn or posterior root attachment of the lateral meniscus that is flipped forward and is inverted. This is the imposter. This is the native anterior horn. And then when I go to the medial meniscus, we're seeing this vertically oriented tear, same distance from the outer margin of the meniscus. And as I'm following it on the coronal, it kind of propagates forward, always staying the same distance from the outer meniscus. So it's at least involving the posterior horn and body of the medial meniscus. And when I line that up with the axial, it shouldn't surprise you that we're able to make out a good chunk of this vertical tear, paralleling the fibers of the C shape of the meniscus. So I think just in the interest of time, I did have more cases, but in the interest of time, I will kind of call it a session so that we could take some questions and get some feedback on the presentation. I'll bring up this last slide so you could kind of see my name and my email address. But I hope that you were able to enjoy this case review live presentation, and I will stick around for questions. All right, so the first question that we're getting is referring to pediatric patients where you see meniscocapsular separation associated with ACL tears. And the question is, how do you differentiate a peripheral vertical tear from meniscocapsular separation? And I think I was trying to allude to that in one of my case discussions. I think that to a certain extent, depending on how thin that meniscal segment becomes, it can be impossible. But if you're able to see the thinnest sliver of meniscal material, meaning like a dark black band of meniscal material attached to the capsule still displaced by the vertical tear, then you could confidently call it a vertical tear. So I think depending on your imaging resolution, the answer to your question that is it might be impossible. Hopefully, I will show that case again where I kind of made an allusion to that phenomenon. Here's the case that I was calling a meniscocapsular separation. Now pretend that there was a tiny dark fragment associated with this portion of the capsule. Then you'd be hard pressed to say, this could be basically a very far peripheral vertical tear where you have the thinnest sliver of meniscal material still attached to the capsule. And I think to a certain extent, this could be just extraordinarily difficult unless you could definitively see like a dark black line. So that's what I'm referencing. I hope that makes some sense. Someone is asking if flap tears and parabeak tears are complex tears per definition. I think that to a certain extent, I think that they can be referred to as complex tears because all the flap tears or parabeak tears, or even complex tears in general, basically involve multiple tear patterns occurring at the same time. With the flap tear, you might have a combination of a horizontal tear and a radial tear. With the parabeak tear, you might have a combination of a radial tear and a longitudinal tear. But once you start combining the basic tear directions, once you have more than one, I believe you could properly call it a complex tear. So if you wanted to in your report, you could say there's a complex tear involving the meniscus with a displaced flap, and that would cover both of those diagnoses, both for parabeak and also for flap tear. It's just important for the surgeon to know that there's a displaced flap of meniscus material because they need to basically go in with that mentality that they need to remove this because any displaced flap of meniscal material creates an unstable situation, and this is going to create problems with clicking, locking, etc. So these fragments do need to be removed. That's a very interesting observation, and I didn't notice it when I was prepping these cases, but I do agree with whoever commented in the chat that we are seeing basically a signal abnormality between the posterior capsule and the posterior horn of the lateral meniscus, and I do think that we could consider this a meniscocapsular separation because normally you have these nice struts that connect. You have your basically meniscocapsular ligaments which nicely connect it, and I don't feel like I'm seeing them as well as I normally do. So I do agree with that observation by Monica. In terms of Michael's question, mucoid and myxoid degeneration are basically the same thing. It's up to semantics. I personally use the word mucoid degeneration even when I'm talking about, like, say I'm talking about mucinous degeneration of the ACL. I would also call that mucoid degeneration of the ACL, whereas some people might call it myxomatous degeneration of the ACL. So to a certain point, it's those terms are interchangeable, and this comes down to semantics and what you get comfortable using. David Payne is asking about the difference between a flap and a flipped tear. Um, I will show one of my kind of bonus examples of the flap tear um, to kind of illustrate one of the points. Um, but with the meniscal flap tear, what winds up happening is you wind up having a meniscal tear where the displaced fragment of meniscus gets displaced into one of the gutters. So whether it gets displaced into the inferior gutter or whether it's coming from the superior surface, it gets displaced into the superior gutter. As you're panning around and looking at the meniscus body, you're going to see that there's going to be this bonus meniscal material either in the superior or inferior gutters. And inevitably, on almost all these cases, there's bone marrow edema located right adjacent to the site of the meniscal tear. Because I get the sense that this bonus meniscal fragment causes irritation to the underlying bone. It gets kind of trapped between the MCL and the medial tibial plateau. On an axial image, very typically when you find these things, you feel like you almost see like a trapdoor phenomenon where the meniscus looks normal here, and then a small portion of the meniscus is basically almost like a trapdoor is basically leaving here and getting displaced right here, deep to the MCL. So this is what's referred to as a flap tear, meaning that you have a displaced flap of meniscus material, not the entire meniscus, just a displaced flap, usually from the undersurface, getting displaced into one of the gutters. Now, the difference between that and one of the flipped meniscus tears, so I'll load up one of those. So we'll look at Caffrey again. So with the flipped meniscus is a variant of a bucket handle tear. And basically with the flipped meniscus, you have a tear that's occurring back here, usually a vertical tear, or it could be basically, so it's usually a vertical tear, similar to our other bucket handle tear descriptions. And then the posterior horn basically completely flips and inverts and inserts itself right behind the anterior horn of the medial meniscus. So this has actually flipped. So it used to be looking like a triangle in this direction, meaning, and then it's completely inverted itself when it's displaced into this location. That's why we refer to it as flipped. Hopefully, so the flap tear is more of like a complex tear that might be a complication of like an oblique tear meeting a radial tear, whereas this flipped meniscus is more of like a bucket handle type of tear. I would think about this as more of a bucket handle like discussion. All right, so someone's asking a great question about how to differentiate between mucoid degeneration and postoperative changes. Um, that's an interesting question. I would say that's um, one approach, which no one does anymore, is if you reliably want to try to look for a meniscal tear in someone that's had previous operation, you could do an MRI arthrogram, meaning that you inject contrast into the joint and you'd be able to tell whether something's a tear versus just post-op changes if contrast was able to get into that tear, because the contrast under pressure would help unmask the tear. I think with the exception of that, with postoperative changes, it's always going to look somewhat like a linear gray area. And I think you just need kind of like a time-wise approach to diagnosis. So to a certain extent, you need serial images, and you need to see if the tear is occurring in a new location relative to the old tear, and take on that type of an approach. I think in some cases it might be difficult. With mucoid degeneration technically doesn't surface. Um, so technically, if we're going to be looking here, let me pull up a case that has some mucoid degeneration. So we talked about this case earlier. Now, mucoid degeneration doesn't surface. And what it looks like is basically like elevated fluid-like signal, intermediate intensity, basically filling the substance of the meniscus, almost producing like a meniscus within a meniscus look. But you see the integrity of these superior and inferior surfaces of the meniscus is maintained. This is like kind of your classic appearance of what mucoid degeneration looks like. Here's an example in this plane. So the key to differentiating mucoid degeneration from a tear is whether or not it's definitively, unequivocally surfacing. And then when you're trying to compare this against basically post-op changes, I believe post-op changes to an extent will surface, and more of a debate will be how do you differentiate post-op changes from a new meniscus tear. And for that, I think the recommendation would be chronologically compare things. And if you're unable to kind of figure that out, you either play the waiting game and do repeat imaging, or you could do an MRI or CT arthrogram to see if contrast is able to get into that tear. And then there was an earlier question, which I believe we kind of touched on, which is, trying to differentiating these far peripheral vertical tears from meniscal capsular separation. And I appreciate the dilemma. I wasn't able to touch on all the dilemmas with menisci. I'm noticing basically it's impossible to cover so much material in a 1-hour slot. Obviously, there's a lot of dilemmas, and it would probably take on another lecture to kind of discuss all the pitfalls of interpreting these images. But I hope that kind of seeing a lot of these examples has kind of given you guys a good foundation of what to think about when you're looking at meniscal tears, kind of how to build that 3-dimensional image in your mind, where you're trying to basically create these scenarios in your mind of what it looks like in 3 dimensions. And then if you're able to do some of this, then the more cases you see, the better you'll get. I would recommend not only seeing cases, but following up to the op note and seeing if the surgeon basically agrees with your diagnosis, and that kind of builds this reinforcement pattern where you'll feel like you're getting more and more accurate at looking at these types of tears. So really try to use all the planes, build the 3D image in your mind of what's going on, and then follow up on all your cases and see how accurate you are. All right, thank you everyone for listening.